Yes, so again, Dave has been an absolutely cracking advocate for us over the past couple of years. He has attended lots of our events. Just as a recap of where we are, so we've had a spotlight on heart valve disease by Benoit Shah, who's talked about the kind of the disease, the epidemiology of the disease. We've then seen live diagnostics with Keith looking at a stethoscope check and an echo, and we've answered questions around some of the diagnostic tools that help us identify the disease. But as we said earlier on in the day, we're in a very different place now than we were last year. People are seeing telemed a lot more, and patients are naturally worried about going into hospital. They're also naturally worried about having a fewer face-to-face sessions. Keith has already talked about still need to see patients in front of us to do lots of the diagnostics. But Dave has had lots of experience over the past couple of months in Wales around the transition to doing more telemed. And this session is around kind of getting to understand your appointment. Dave's going to talk a little bit about the kind of what's been happening during COVID as a reflection of his experiences and what we've seen across the UK, and then move into that telemed environment, and then we'll touch on some of the resources that are available to patients. So Dave, I'll leave it over to you.
Thanks, Will. As you say, I'm not going to use the unprecedented word. We've heard that far too much already, I think, this year, but clearly we've been through a very bizarre and unheralded time for us in terms of how we actually see, meet, discuss, review, and manage the patients that we see. And clearly, whilst none of us would have chosen to undergo a pandemic to be shown new ways of working, we have been shown new ways of working. And I think that this is something for us to take the good bits out of the COVID pandemic and hopefully use them to our benefit. And when I say our, I mean the benefit of the patient and also the benefit of the medical professionals who are caring for patients with heart valve disease. For many patients with heart valve disease, it's not a one-stop shop. You don't just go to hospital or have one single appointment. For many patients, this is a pathway approach which may undertake many reviews, many ongoing repeat assessments, and therefore our mode and method of communication is likely to, I think, beneficially change as a result of COVID. Luckily, Heart Valve Voice have produced a virtual appointment guide to try and give us a little bit of a framework as to how we can best optimize the reviews that we have, whether that is still face-to-face, which, as you've heard already, may still be the case, or may be the case moving forwards, that we have more virtual appointments. Certainly, I think for follow-up appointments, it's highly likely that more of our reviews are going to be done virtually. So the virtual appointment guide, I think, is very helpful and it gives us a framework with which to really hopefully concentrate our thoughts about optimizing the interaction with the medical health professional that you're in front of. And Simon's clearly and kindly shared the screen there showing the virtual appointment guide. And before we go through it, I think I would sort of start off by saying this is an opportunity to focus on you, your symptoms, and your future management, as opposed to having to worry about getting someone to drive me to a hospital appointment, finding a parking space, finding the clinic room within the hospital, etc., etc. This is hopefully a time to focus on you, your symptoms, and your needs, healthcare needs, moving forward. So Will, that's sort of a start of a 10, if you like. Would you like me to start walking through the virtual appointment guide?
Yes, that'd be good. Yeah, be good. And then, like I said, just to talk about some of the experiences that your clinic's been having during the kind of COVID environment and how this.
So in the COVID era, we've gone through clearly a virtual shutdown of most elective services, where we were prioritising people who we'd identified as being a slightly higher risk compared to other patients, whereas really since the end of May and the start of June, we've been sort of getting back, I wouldn't say to normal, but we've been getting back to try and catch up with a lot of the people that we didn't unfortunately meet and liaise with during the height of the COVID pandemic. We're still seeing people face to face, and that will be certainly be the case for the first time, or what we call new patient appointment, but virtually all of our follow-up appointments currently, where we're reviewing symptoms, and we'll come back to that throughout the course of this talk, we are doing virtually, and that is something that we found to be really quite useful. So as you can see here from the virtual appointment guide, I think it's clear that we need to consider how we prepare ourselves for this consultation. Historically, we would have gone to a clinic room to see a doctor or a healthcare professional face to face, but clearly now we're doing this hopefully virtually, either telephonic consultation or ideally a video consultation where we can see each other and talk to each other. And what we need to consider is clearly, what do we want to get out of this consultation? What information do you need to get over from yourself with your symptoms, how it's affecting your quality of life, to the healthcare professional you're liaising with? And certainly perhaps for the first appointment, whatever form that takes, it might be sensible that you bring either a family member or a friend, simply because there's usually quite a lot of information to impart, and actually to remember all of the salient information on your own can be quite difficult. So perhaps less so for follow-up appointments, but certainly for a first-time consultation, I think it would be very helpful to have a friend or family member present who can help both nudge you, if you like, in terms of making sure you get out of the call what you need to tell the healthcare professional, but also in terms of remembering all of the details of the consultation as well. So there needs to be some preparatory work done. You need to be able to connect with the technology. That may require a friend or family member. You also need to have a method of recording the consultation and the information imparted from that as well. So the key thing that a healthcare professional wants to get from the history is, firstly, the symptoms that you're experiencing. Is that breathlessness, for example? Is it dizziness or lightheadedness? Is it a combination of both? Is it chest discomfort? So a healthcare professional will want to ascertain the symptoms, firstly, that you're experiencing, and then they will want to find out how those symptoms are impacting upon your daily activity, your quality of life. We hear this phrase a lot, but it really means how you are able to undertake your daily activities. And certainly, in addition to that, we'll want to know if there's been a change in your daily activities, your ability to undertake these daily activities. So it's a two-way process. We need to be listening and hearing, and we need to be making sure that we've got an accurate assessment of symptoms and impact on daily activities. So Simon, can you scroll through to the next page there, if you don't mind? So this is reflected on the second page of the virtual appointment guide. And what we're really after to say is what symptoms you're experiencing, but how this really is affecting you and how it is increasingly affected you. If symptoms have been present but been there for clearly a long time and unchanged, it's less of a concern to the healthcare professional than a recent change, a recent deterioration in your ability to undertake your daily activities. So this two-way listening, describing process is key for any healthcare professional when we're assessing how symptoms are affecting you, and equally where you are on your potential pathway. So, for example, many patients don't actually require treatment at the first time of clinic review. Most patients will require what we call active monitoring. And that active monitoring is really driven by the symptoms, the change in symptoms, and the change in your ability to undertake your daily activities. And on the third part, the third column of the virtual appointment guide, it is really talking about what we call your pathway. In other words, once we have ascertained what the problem is, i.e. the diagnosis, and that might require further investigation, the pathway focus then is, well, what do we need to do? What treatment, if any, is viable? What treatment needs to be performed? And for most people with heart valve disease, that is usually a period, once the diagnosis and the initial investigations have been achieved and undertaken, we really need to sort of set the scene. Do I need treatment, or is this something that's going to be kept under review and monitored? And for the majority of people, the latter is true. Monitoring and surveillance is going to be the pathway for them. There will be a minority of people who perhaps present at a more advanced stage of valve disease who will require sooner treatment, but the majority of people will require surveillance and then potential future treatment. And the way we ascertain that is really through a symptom burden, as well as the information obtained from the diagnostic imaging, whether that's an echo ultrasound for assessment of the heart valve. Sometimes we may undertake other investigations which are more complex, CT body scanning, invasive tests. But for the majority of people, symptoms in combination with their echocardiogram over time is going to determine where they are on this treatment pathway. Simon, if you can scroll to the last page, the third page of the virtual guide.
Thanks, Simon. And if you can maybe pick that up. I think he was just removing someone from the group again. There we go.
There we go, brilliant. So this is the final page of the virtual appointment guide, and it really just sort of gives a way to conclude or sum up and reflect on the consultation. And the first part of this really is to make sure that you're happy and understand what has been described and what's been discussed during the consultation. And the bottom point there in the blue row, ask questions if you're unclear, is absolutely key. And as doctors and healthcare professionals, we should be doing this as well. We need to make sure that we're both understanding what's been discussed, what the plans are, what the future is likely to hold in terms of next appointments, which is the middle column there, and what the plan for follow-up is, what the nature of that's going to be moving forward. Will that be face-to-face? Will it be virtual? As I said at the start, it's probably most likely that a lot of follow-up appointments, review appointments, are likely to be virtual moving forward. And the final column there is knowing who you should contact. And that's important not only if you need to ask questions, but also if your symptoms change. This needs to be a dynamic review process. We arbitrarily set dates and timeframes for follow-up, but of course we may find that our symptoms change before that appointment. And so it's important to know who you should be contacting if that is the case. Or equally, if you have a question that arises about your treatment, your pathway, or anything to do with your care. So this is a way really of just summarizing that we're happy with the consultation, we've understood what was discussed, we understand what the future appointment is going to be, when it's going to be, and who I should actually contact if my symptoms change before that planned appointment date. So the virtual appointment guide, I think, gives us a framework to work within so that we can all focus on optimizing the interaction between patient and healthcare professional, and making sure that we get out of it all that we need to get out of it.
Superb. So when COVID, when the pandemic struck, as you know, lots of patients were very worried about presenting into hospital with any kind of cardiovascular disease, and we saw that reflect in a lot of cases with people turning up almost too late or in very advanced cardiovascular problems. Through the Global Heart Hub, we delivered a Just Go campaign to reassure patients that hospital and NHS was open for business and that we could treat effectively, quickly. And our campaign focused around 4 patients that were treated at the height of COVID, were brought into hospital with changes in their symptoms, were treated and were back home, and are doing well. And many have now become advocates for us, which is great. That Just Go campaign was a global campaign and hit over 800 million people. So it was a real success. But Dave, can you tell me, what was it like in a clinic during COVID? What is it like now? And any kind of messages to patients who are not treated or are in fact treated now, but as we go into the winter months, some of the fears that they may have?
I guess, as you say, first time around back in March, because of the nature of the circumstances, it would be fair to say that we were all at 6s and 7s with what would be the best thing to do for the patients. We always knew that there is a balance to be had. There was a balance to be had at the time between the risks of the heart valve disease causing a worsening health status for individual patients. And there was obviously a growing problem with the potential infection from a pandemic that we'd never seen before, was new to these shores and was new worldwide. I think where we are now is a remarkably different place to where we were back in March. We've clearly learned a lot more about COVID itself, and how to deal with it and how to prevent it. And within every single hospital in the UK, there have been lots of processes and protocols put in place to make sure that we safeguard the well-being of patients and prevent them from getting COVID as far as we can. And if we now look at the COVID state of hospitals in the UK, it is a much better place with lower patient admissions with COVID, lower rates of adverse outcomes, thankfully, than we had back in March and April. And I would hope, and I do believe is the case, we've certainly learned a lot more about how to best manage the COVID pandemic in light of a potential second wave of this, which we're beginning to clearly be concerned about moving forward. From a heart valve point of view, we've also learned how to make more efficient and effective our care for heart valve patients during the COVID pandemic as well. As you hinted at, we've learned to hopefully improve the efficiency of consultations. So we're able to do more on a one-stop shop basis with clinical review of patients. So they spend less time in a hospital being reviewed, having tests, etc. If patients are coming in for heart valve treatments, we've also been able to make their duration of hospital stay shorter by making certain efficiencies for the care pathway for the procedural element of care. And as a result, I would hope that we're able to reassure patients that should they require in-hospital review or in-hospital therapy for their heart valve disease, we're able to do this in a manner that reduces to a minimum their risk of contracting the coronavirus, while secondly, minimizing the duration of their time spent in hospital, whilst not compromising the quality of care that they receive.
So we've got a couple of questions coming in from lots of the social media channels and through the chat. So some of these might be slightly off topic, Dave, but well within your expertise, so I'm going to throw them at you. Donald had a question about, he believes he's got a bit of a problem with one of his heart valves, and he's having some rhythm problems. Should he seek attention for that?
Yes, the actual review of those symptoms can be easily carried out. That could also be done virtually. It may be the case that we would wish to perform some heart rhythm monitoring. And that is something that could be done very easily with minimal in-hospital contact. For example, in my hospital, we've now got a drive-through heart monitor availability, whereby patients will probably spend, I'm guessing, probably about 10 to 15 minutes tops while still in their car being fitted with a heart valve, a heart rhythm monitor. So the answer to that is yes, I would certainly seek a review, which can be done face-to-face or virtually, to discuss again the symptoms, the nature of them, so that the healthcare professional can get an idea of what might be going on. I suspect that the likely investigation will be a heart rhythm monitor, which will require, as I say, probably a 15 to 20 minute in-hospital period. And then once that has been performed, the heart rhythm can be interrogated and the results can be received virtually, and a recommendation for treatment, if needed, can also be delivered without needing to come to hospital as well. So as always, yes, I would seek review and go through that process, which I think will require minimal in-hospital time.
So there's a question from Sigal Bull, but I'm not quite clear on it. So I don't know whether you can just send us a little bit more information on that. But we do have a question about the longevity of treatments. Dave, I don't know whether you want to jump in with this one. So there was a question around having a tissue valve, and was discharged back in 2012. But what is the kind of average life of that and that valve, and when should people start thinking about the symptoms again? So
yeah,
it's a specific one.
Durability and longevity of tissue heart valves is quite a hot topic, and I guess it's been made hotter because of the TAVI era. However, we've been implanting tissue valves for decades now, and actually what we've noted is that the durability is increasing all of the time. So certainly I would have no hesitation to say that the majority of tissue valves will last you a minimum of 15 years. That's pretty good data for that these days. In terms of how should we monitor whether a tissue valve is beginning to degenerate or not, what you should receive is a yearly echocardiogram, the ultrasound assessment of your heart valve, so that we can assess its function, and we can also compare it to what we've known of its function before. So for the majority of patients, 15 years, I would say, is the sort of the quoted minimum now for tissue valves. And to give everyone a bit of peace of mind, but also some evidence of what the function of the tissue valve is that you should receive a yearly transthoracic jelly on the chest echocardiogram, so that we can have some evidence with which to assess your heart valve, and also dynamically each year assess its function compared to the function we've known previously.
Two questions, one from Victor and another one from, I'm thinking this is a Twitter question. Sometimes patients feel a little bit confused with the kind of terminology that's used to measure the word leak. And what kind of questions should we be asking in your consultation if you're worried about that? And then a second one linked again to how long should you wait before you call somebody if you're noticing symptoms changing, and whether you can give a little bit of a reassurance of the kind of time that you should wait.
Yeah, sure. I guess that partially depends on the symptoms themselves. Firstly, the most worrying symptom that we as medical professionals worry about is when people either pass out or they feel they may pass out. That for us is a bit of a red flag. And that's something that we would always say, that's something you should be phoning 999 about. That's the worst end of the spectrum. Okay, and whatever the underlying problem, if it's causing people to pass out, for me, that is the red flag to say you need to seek urgent medical opinion. And by that, I mean a 999 call or presentation at an acute medical facility. In terms of the other end of the spectrum, let's say your symptom is breathlessness. We all will get breathless. Not that we should underplay our symptoms, but it's a symptom that requires a non-emergent consultation, I would say. So if you are presenting with breathlessness for the first time, I would say that that is something that you should make a review appointment with your healthcare professionals, usually your primary care practitioner, your GP, to start off with. And that's something that I think should be within a time frame of weeks to have that new appointment. If you have a known diagnosis and you've already been for your initial appointment and you're being reviewed, so you're looking at a change in symptoms, it depends on the time frame that you've noticed this and the severity of that breathlessness. If this is something you've noticed over the last few months or longer, I would say this is something that, again, that will require a non-urgent review. It requires review and reassessment, but not on an urgent basis. If this is something that you've noticed over days to weeks, and it, again, coming back to the virtual appointment guide, it is limiting your daily activity and it is getting worse, this is something that you need to be seeking a days to weeks consultation about, not letting this go for weeks and months without being reviewed. So I think there's a spectrum of, dare I say it rudely, common sense to that answer. There will be clearly a spectrum of answers, which is you should get on the phone to 999 and I think I'd like to see you acutely this day. Or there, on the other end of the spectrum, there are, yes, there's symptoms or a change in symptoms. I need to seek a review, but it doesn't need to be urgent or emergent.
Superb. Yeah, just a few comments going on about the differences across the country in wait times, particularly for echo. That seems to be emerging. And maybe a little couple of sentences on that. Any other questions, Simon? Are you seeing any more?
Yeah, I've had to just suspend the chat function because of the unwanted comments that were put earlier. So if there were, I've sent you a message and to Elska. I don't know if Elska's seen it, but so I think I'll rely on Elska and if you keep an eye on the Twitter, and Elska's going to highlight Facebook questions and things, I think. But I've shared a copy of the agenda for one of our audience members who was keen. We've covered the pig valve question that I popped in the. Have we covered that? Yeah. Okay. So I think we're good for questions just now.
Superb.
Yeah.
Okay. Well, thank you very much for your time, Dave. We've been, like I said, been streaming out on Facebook Live and on Twitter. And we've got a healthy audience here in the webinar room. So I think it's a natural coffee break now. And we'll come back at 12:15 with a session on the patient pathway delivered by Dr. Chris Arden. So getting to know your valve disease pathway, right from primary care to treatment. We will then have some patient interviews, and then we move into women in surgery and carers, families and friends sessions at 1:15. So we've got an opportunity to refill a coffee cup and we can rejoin. So will we close down the group and ask our delegates to jump back in, or leave it open?
I'll leave it open. I would just say for audience members, any questions, pop them in the Q&A. You can still do that. And in the Q&A, they are not shared publicly. So I think it's probably best I'll leave the chat closed for now, because we don't have any other system for just being able to prevent untoward comments coming on there. I think it's one of the challenges of having a public-facing event, and it's been promoted widely, and people can click a link and join without having to go through any screen, to make it easy for patients themselves and family members to learn about heart valve disease and how to aspects of the condition, aspects of the service and the treatment pathway. So I will restate this when we come back, but if you keep the questions coming in through the Q&A tab, and I'll just unfortunately have to suspend the chat. I would encourage anybody, if you want to make comments, put them on the Facebook page. Is that a fair comment? Will?
Yeah, the team are monitoring that as well, but yeah, the Q&A will be the best place. Wonderful.
Okay.
Thank you very much again, Dave, for taking some time out of your busy schedule.
Pleasure.
Thank you, Dave. So, we have a 45-minute break, so an early lunch, get a little bit of fresh air, have a stretch, and look forward to coming back a little bit later. I'll give you a call, Will. And okay.
Thank you.
Thanks, everybody. Bye-bye.